Well, good morning, everyone, all colleagues and friends. So I am Emmanuelle Cambeau. I'm professor in clinical microbiology in Paris, France. And it's my pleasure to introduce Professor Vikram Patel. He's professor of global health at Harvard University, but he's also leading several groups around the world. And he will speak about transforming mental health care in the COVID era. And I'm sure, like me, you're very uh, interested in listening him. Thank you, Vikram. The floor
Thank
is
you
yours.
so much. Well, thank you so much for inviting me. I think the very fact that a major infectious diseases conference is having a lecture on the subject of mental health could only have happened because of the COVID era. And I think it's because the COVID era has reminded each and every one of us about why our mental health is so important. In many ways, I see where we are right now as the acute phase of the COVID pandemic. In many parts of the world, in India, where I'm currently locked down, but also in Europe and the US, where I'm headed next week, there are still very significant concerns about the control of the pandemic. And as a result, many different uncertainties about our lives. And you can just see some examples of the sorts of different uncertainties that people are having to deal with. Some of us deal with a few of these, some of us deal with some others. But I think for all of us, there is a general uncertainty about the world will begin to look like the way it was before the pandemic hit us. And I think it's important to recognize that uncertainty also comes alongside the loss of control, the loss of sense that I am in control of my life, about my destiny. And it is this combination that is really the greatest stress on our mental health. Now, of course, uncertainty is part of everyday life. For example, the uncertainty of whether or not I will deliver this lecture in a proper way is going to create a degree of stress in me and is going to make me feel a little anxious, a little aroused. And actually, that kind of uncertainty can actually make you more alert and much more productive and effective. But it is when uncertainty is chronic, persistent, with no obvious sign of ending, that is when that kind of uncertainty begins to affect one's mental health in a negative way. In the acute phase, I would say many of the emotional reactions that all of us experience and see around us, I would read that as a normal reaction of the human brain, the human mind, to a very unnatural, extraordinary situation. But as uncertainties persist, I believe that we are going to be seeing a rise in clinically significant mental health problems. In fact, we're already seeing that rise in the weeks, months, and years ahead. It's important also to recognize that these uncertainties affect subgroups in the population in very different ways. Those of us who are fortunate, for example, to have salaried jobs, such as I do as a university professor, have found that the uncertainty of work hasn't actually affected my economic status. In fact, it's actually been something that I've enjoyed doing, being able to work from home, for example. But as you can see on this slide here, there are a variety of subgroups in the population who are affected in very differential ways. And so the impact on their mental health is also going to be very differential. Consider in India, for example, that hundreds of millions of people who live on daily wage jobs, which means that when there is a lockdown, they basically stop earning completely for the days that their particular job is stopped. And this means immediate poverty, immediate hunger, immediate desperation. And I think that is a very good example of how a lockdown as a policy can have very differential effects on different subgroups in the population. And as a society, therefore, we have to be particularly concerned about those vulnerable populations. Another really important example is to do with children and young people. It's very important for us to remember that when we talk about school closures, that the single most affected population is not the teacher, it's not the parent, it's actually the child himself or herself. And it's also important to remember that schools are not just places where you go to learn geography and history, but they're also places in which one's mental health is promoted through social interactions. And so whereas you can move many of the learning tasks to Zoom platforms, you can't really move some of the other social development tasks to Zoom just as easily. It's also important when you think of children, for example, to think of their parents who are now finding that not only do they have to work from home, but they also have to look after their children. So I think there are very complex layers in which some of the containment policies that have been rolled out in different countries can affect people in differential ways that will then affect their mental health. There's been many, many different initiatives. This is a slide coming from a forthcoming paper, and you don't have to read each of these different examples. This is a review that we've done on the sorts of interventions that we're seeing in low and middle income countries in particular to address mental health needs. And what's really reassuring is a recognition in many parts of the world that mental health needs are really important to be addressed concurrently with policies to contain the pandemic. Unfortunately, of course, these are really patchy and most of them will not be sustained beyond the period of the pandemic, although I wish they are. And the other important caveat is most of these are remotely delivered interventions, which in many parts of Africa and Asia mean that a significant proportion of the population that does not have access to the internet or to their own devices are going to be left behind. I'm perhaps more concerned about what the future holds. By the World Bank president's own estimate, as many as 100 million people have been pushed into extreme poverty. Underline extreme because, of course, far greater numbers of people have seen their economic well-being affected than extreme poverty. Extreme poverty means you basically have no money to even feed yourself. And this is an astonishing statistic when you consider the impact that extreme poverty has on health and well-being, not least mental health. About 6 months ago, the Nobel Prize-winning economist Angus Deaton and his colleague Anne Case produced this book that documented the reasons behind the increased mortality and reduced life expectancy in working-class Americans, mostly white Americans, following the financial crisis of 2008, which really particularly affected the US, and demonstrate that most of this mortality was driven by suicide and substance use. This time round, the economic recession is far worse, and it is also global. And so it isn't the case that all the other countries of the world could help America return back into an economically strong position, because every country is now struggling with the economic fallout of the pandemic. And so I do worry about what the future holds. And in particular, I worry because the situation for mental health care before COVID was also very, very poor. Already before COVID, we were able to show that in the last 25 years, this is the global burden of disease metrics of DALYs attributable to mental and substance use disorders. And over the past 25 years, no matter which country you lived in, whether it was a low sustainable development index country or a high one, that over the past 25 years, the relative burden of mental and substance use disorders has grown by 50%. In part, of course, that's because countries have been more successful in controlling the burden of other health conditions and done spectacularly badly when it comes to mental and substance use conditions. Another reason why the burden has increased, and particularly in low and middle income countries, is evident on this slide, which shows you the burden of disease by across the life course on the y-axis for men and for women. And what you can see clearly is that the burden is greatest in young adulthood between the ages of 15 and 45. And of course, this is the largest segment of the population in developing countries. But it is also the largest segment of the population in the workforce. And so this is really important when you consider the impact of mental health problems on economic productivity of all societies. Although traditionally in the Global Burden of Disease report, the numbers of deaths that can be specifically attributed to mental health conditions is quite small, just about 1 million each year. This is also because of a really strange way in that cause-specific mortality is classified in the ICD. So for example, suicide is classified under the category of injuries. When you actually include all deaths that are an excess mortality that occur because of mental, neurological, and substance use conditions. In fact, the total number exceeds 13 million in the same year as this particular estimate comes from for cause-specific mortality. And much of that large number of deaths is accounted for by suicide and substance use-related mortality. Now, in spite of the evidence of burden of mental and substance use disorders and the premature mortality that are as a result of these conditions, the question we have to ask ourselves is how successful have countries been in assuring coverage of minimally effective treatment? And here I'm going to show you the coverage rates for depression, anxiety, and substance use conditions. Put together, this accounts for about 70% of the total burden of mental health conditions in any population. Let's first look at the coverage for these conditions in low and middle income countries. And it's an astonishing finding, really. More than 95% of people with these conditions in these countries, about 80% of the world's population, have not received minimally effective treatment. In my estimation, this makes it the largest unmet need for healthcare for any health condition in the world. Now, in high-income countries, such as in Europe and North America, which have 1,000 times more resources spent on mental health care in the form of dollars spent per capita on mental health specialists, on mental health care inpatient units, and so on, you'd expect a much, much, much better coverage rate. Well, you do see a much better coverage rate, but nowhere near the kind of rates that one would want to see in the wealthiest countries of the world that are already spending so much on mental health care. The average coverage rates, of course, there's a lot of variation between countries, actually doesn't exceed 75% for any of these conditions. And I want to really emphasize this point here because it suggests that it isn't just the amount of money that we're spending on mental health care that's important, but also what we're spending that money on, which currently is dominated by specialized services led by mental health professionals with very narrow biomedical approaches for care. And I'm going to suggest to you that that is not the future of what mental health care investment should look like. Unfortunately, in many parts of the world, mental health care continues to look like this. These are images of mental hospitals not taken 100 years ago, but actually taken in the last decade from a variety of countries in Eastern Europe, South Asia, and in Africa. And this is the kind of torturous sites that perhaps we haven't seen in Europe for at least 100 years, but continue to blot the landscape of mental health care in many parts of the world, something my colleague Arthur Kleinman has referred to as a failure of humanity. In many developed countries, of course, we don't see these kinds of asylums that used to be very dominant 100 years ago. But in many countries like the US, the country that I live in, actually we've just replaced the asylum with the prison. So it's a little bit of like a diversion. We've shut down the asylum, but we've really filled our prisons, particularly in the US here, with people with serious mental illness. And of course, it's really important to remember that when we talk about stigma, that stigma is in part at least produced by the nature of mental health care that has been characterized by coercion, by involuntary treatment, and by institutionalization. This is a very important reason why people are often reluctant to seek mental health care. I want to now pivot to the opportunity that I think we need to embrace in the COVID era. About 15 years ago, I was asked by the National Institutes of Health in the US to co-chair a Grand Challenges priority setting exercise to identify the leading research priorities in mental health that, if addressed, could help reduce the burden of mental health problems. We did a classic Delphi-style priority setting exercise and found that the 5 leading research priorities didn't fall into the domain of discovery research. They were not questions like what's the gene for schizophrenia or a molecular target for neuromodulation therapy, but actually it was about implementation science. How can we deliver more effectively the evidence, the knowledge that we already have in the field of mental health care? In the last decade, led by the National Institutes of Health, the Wellcome Trust, the European Union Horizons Program, the Grand Challenges Canada Program, more than $500 million of new money has been spent on implementation science in the mental health field with a very strong focus on the global South, places where there are very few mental health professionals. And today, I can confidently tell you that thanks to this body of knowledge, more than 100 randomized controlled trials from around the world, we know how to deliver clinical and preventative interventions using existing resources in the community, and of course, almost always, that is non-specialized resources in the form of community health workers, peer support workers, nurses, midwives, and so on, in an affordable and acceptable way. And of course, the most important piece, of course, is that these interventions are effective, far more effective than what people are receiving currently. It is this body of evidence that has completely redefined what mental health care looks like, not just in developing countries, but I propose to you that this is also how mental health care should be redefined in the wealthiest countries of the world. And I'm going to give you examples of each of these 4 different domains. Because time limits me, I will only give you one example of each. In the what domain, the mental health care clearly needs to combine clinical interventions that are targeting the symptoms of mental health problems with social interventions, because mental health problems almost always coexist with social disadvantage and other social determinants. Where? Mental health care can be delivered pretty much anywhere that the person is suffering. And in fact, some of the most exciting interventions are being delivered at home, particularly relevant for people with enduring mental health conditions who often find it very hard to come to hospitals and clinics. Who? Pretty much anyone in the community can be trained to deliver mental health care, provided the how is done, which is carefully designed, competency-based training, followed by quality assurance through systematic supervision, and all of this done in a coordinated fashion so that these frontline providers are delivering first responder care within a coordinated mental health care system. It is this evidence that is really transforming policy both at the national and at the global level. And here are some examples of recent policy documents that have embraced some of this evidence. I was a member of the World Health Organization's Independent High-Level Commission for Non-Communicable Diseases, which for the first time included mental health problems alongside the other NCDs like heart disease and diabetes. The World Health Organization's Mental Health Action Plan, agreed by all nations of the world. The World Bank's Disease Control Priorities Program, where I led the specific task force on mental, neurological, and substance use disorders, and the UN Sustainable Development Goals. All of these have embraced the notion of community-facing mental health care with the engagement of non-specialized providers as a fundamental foundation of the mental health care system. A few years ago, the editor of The Lancet, Richard Horton, invited me to put together a group to examine this exciting new evidence that is allowing us to reimagine mental health care and to examine what the implications of this evidence was for the future of mental health care. Of course, we could not have anticipated COVID-19 then, but I think this evidence has become even more urgent and even more relevant in the COVID era. We published our report in 2018. This was launched in 10 Downing Street, in fact, by the then Prime Minister of Britain. And I want to just summarize to you some of the key messages that the report has recommended, which, as I said, are very relevant even today. The first is that we need to look beyond narrowly defined biomedical categories of mental illness. We have followed in the mental health area the infectious disease paradigm, in which we can divide the world into people with TB and without TB, or with COVID-19 and without COVID-19. But the dimensional nature of mental health clearly indicates that this is an inappropriate strategy for mental health problems, because all mental health problems ultimately lie on a dimension or a spectrum. We need to now re-emphasize actions for prevention, because we do know what are the major adversities or determinants for poor mental health, and they are largely clustered in the environments that children and adolescents face, that is to say, in the early part of the life course. And what we do need to do is to emphasize preventative actions that promote nurturing environments, even though that most of these interventions lie outside the health sector. I think we should not ignore the potential for prevention. The third, we will not be able to scale up mental health care unless people with a lived experience and their expectations are bang in the center of every single thing we do in planning and delivering mental health care. And the single most important desire that people with a lived experience have is to respect their autonomy to make decisions about healthcare. And therefore, a rights-based approach that seeks to ultimately eliminate coercion and institutionalization in mental health care that respects the dignity and the rights of people with mental health problems is a fundamentally important recommendation. And finally, to scale up the exciting evidence that I presented earlier, that task sharing of psychosocial interventions to frontline workers is the most important immediate task that we should invest in so that we can scale up the evidence of what works around the world. This, friends, is what I'm engaged in right now. I'm engaged in actually many activities, but I want to end by telling you about a particular initiative that I'm really excited about, which is the EMPOWER initiative of Harvard Medical School, which is also working in many developing countries, which essentially wants to use digital technology not to provide yet another app for people who have mental health problems to sit and figure out how to fix their own minds, but actually a digital solution for building a workforce that is capable of learning, mastering, and delivering quality assured, brief psychological treatments. And it's important to specify that most people, when they have a mental health problem, would rather see a skilled provider, either remotely or in person, rather than sit with their phones and try and work their way through an app. It's really interesting. You know, the tech industry has made us believe that actually people will fix themselves with apps. Actually, there are thousands of apps out there, but very, very low uptake of those apps in the real world. We're building a series of digital tools, building on very established technologies, nothing terribly new here, but it's really the connecting of all of these different tools across a pathway that enables frontline providers to learn how to deliver psychological treatments using, of course, modern pedagogical science, then using online platforms for supporting case-based learning to master the delivery of those treatments, but then also to have continuing quality assurance with quantifiable metrics. And finally, at the system level, to enable healthcare systems to evaluate the impact of this scaling up on population mental health and to use data science as a way to actually constantly improve the precision with which these treatments are delivered, and also the content of these treatments, so that you can identify which components of quality actually predict the outcomes at the patient level, and then use that in feedback loops to further improve the effectiveness of the intervention. Ultimately, what EMPOWER would do is to take a naive learner, such as a community-based worker, to become a competent learner after completing a course, then through case-based supervision to become a competent provider and become credentialed. And over time, as they deliver interventions to larger and larger numbers of people, they graduate to become experts who can then actually become moderators and supervisors for the next generation of learners. And as you can see here, an inbuilt system for sustainability. And so that as you build a larger and larger pool of trained providers to deliver mental health interventions, as opposed to the current system where the rising demand for mental health care simply cannot be met by the mental health system that is currently in place, that what we do through EMPOWER is build an unlimited supply theoretically for mental health care, and therefore exponentially increase the number of people who you can help. Ultimately, what the Lancet Commission called for is to reframe mental health not just as a biomedical disease entity, but as a universal human quality, which is indivisible from physical health, important to people in all countries, including wealthy countries, especially important to young people, because this is the age of maximum onset of mental health problems, and is a crucial contributor to human capital. In closing, I believe that the COVID era offers us a historic opportunity to invest in and transform mental health care systems in all countries. It is absolutely true that while we need more money, we will also need that money to be spent wisely, guided by the best science. Mental health care, therefore, must embrace the diversity of experiences and strategies which work well beyond the emphasis on doctors, diagnoses, and drugs. Thank you very much.
Thank you very much, Dr. Patel, for a very inspiring talk. And I really like your idea to take the care out of specialist hands and put it into community-based treatment. We have two questions here, and I'll read the first one for you. How do you view school closures on the light of your discussion can that not have long-term impact that is much more problematic than keeping them open and trying out cohort strategies and send classes home if there are positive cases? So this is about school. How does it affect?
I am absolutely clear about this. School closures must be done in consultation with children. I think children's voices have been completely absent. Young people's voices have been completely absent as we grown-ups have essentially thrown their entire lives under the bus. To protect ourselves from the virus, we've essentially sacrificed the needs of our children and adolescents. And I think that goes completely against the grain of participatory decision-making. I personally believe that schools should be open because schools are far more than places where you learn things. And you know what? In many developing countries, schools are also the only place where children get food. Actually, this is also true of the US, by the way. For many of the low-income populations in the US, the single most nourishing meal that a child gets is actually the school lunch. And so when you close school, you also break down nutrition. So I do think we've done this decision without actually children in mind. We've done it for our own personal interests. I think opening schools in a safe way, and I do think safety is important, of course, not least the safety of teachers, can be done. I think if we apply ourselves, there are ways of doing this rather than simply having a blanket closing school policy. There are already some estimates, by the way, that the lost learning potential in the last 6 months for children around the world is going to be catastrophic for many parts of the world, particularly children who come from low-income families who do not have access to parents who can support their learning needs and have digital access to good remote online learning.
Thank you very much. So the next question is, how do you have any suggestion for how healthcare workers overcome fear and anxiety?
Yeah, well, first of all, I think one of the gravest concerns for healthcare workers is understanding risk. And of course, we're still learning so much about this virus. To be honest, what we thought about 6 months ago and what we know now is so vastly different. If you remember, 6 months ago, this virus was seen as being far more deadly than we know it is. And I think for even this whole interesting question that's going on right now, is it an aerosol borne or not? I mean, this has a very important implication for healthcare workers. And so unfortunately, this is the real uncertainty for healthcare workers. I would say that we need to obviously have a higher level of protection for all healthcare workers for obvious reasons. And it is really, really important that healthcare workers are provided with the necessary protection, but also with the necessary time off in order to be able to deal with the hard work that they're dealing with, they're coping with. In Harvard Medical School, we have a very strong service for all our healthcare workers to support their mental health needs, including peer support. It's never going to be sufficient because this is a very stressful time for people working on the front lines of COVID, but at least it helps somehow to minimize some of those stresses. The other thing I will say is the moment we have a clear recommendation, for example, on risk of transmission in healthcare tasks, we must make this widely communicated so there is no doubt in people's minds about what is safe and what isn't and what kind of personal protection people should be using.
Yeah, so that means that it's really up to the national authorities to draw up guidelines and the recommendations based on. But I mean, yeah,
I have a questions. May I ask them? Yeah.
Of course, go ahead.
After COVID or during COVID, do you fear an increase in the use of drugs? Could be medical drugs or forbidden ones like heroin and so?
Well, if you see the pattern that happened in the US, of course, the US is a very particular context of opioids, which hopefully will not happen again because of the lessons we've learned. But there are many other drugs that are widely available and used, like benzodiazepines, very easily obtained by any general practitioner. So I do worry, but I think the most important drug to think about is alcohol, which is already, a very major cause of mortality in many wealthy countries. And I absolutely think that this is where we need to be conscious that there may be a rise in liver disease and accidents and injuries, etc., due to heavy drinking. And so therefore strengthening mental health services services always includes also strengthening substance use services, which somehow we don't have always acknowledge as a mental health issue. You know, we usually ignore it as a moral problem or a law and order problem, but actually it is a health problem. It's an addiction, and I think we must strengthen those services too.
So thank you very much, Dr. Patel. I think the time is up, so we have to close the session. And being an ID specialist, I learned a lot, and I think your Empower initiative is really great. So congratulations, and thank you very much for being with ESCMID this afternoon from India. Thank you very much, everybody.
Thank you very much.
Thank you. Bye-bye.